today we're going to talk about managing symptoms in the actively dying patient. And you are probably more experts than I am, so if you see something that doesn't sound quite right, raise your hand. Let's talk about it. So Mrs. Gohart. So she's been in hospice for about 2 months. She has end-stage heart disease and was hospitalized for a heart attack prior to coming to hospice. She's short of breath at rest. She became bedbound a week ago, became progressively more confused, stopped eating and drinking yesterday. She's now minimally responsive. Her son, George, who's sitting at her bedside, wants to know what to expect and what can we do to help keep her comfortable. What do you think? What can we tell him about what to expect first? What do you think is going to happen? I don't know. Maybe she's going to die. Do you think George has probably seen someone die before? What? Maybe someone else in his family? What kind of experience do you think he's had of death and dying in our society? I'm sorry? A pet, maybe? Hospital? Maybe he's watched some movies. What happens in movies when people are dying? The gold is buried in the backyard. So probably he doesn't have a very realistic expectation. What do we notice when people are dying? Change in breathing pattern. Thanks, Holly. Change in color. Yes. Stop eating and drinking. Sorry, Lene.
Terminal agitation.
Terminal agitation. So his mom might become very agitated. That's important to know. Withdrawing from people? Absolutely. Confusion. Fluid buildup? Absolutely. Modeling. Fevers and gurgling. So all different things. And this might be very scary to George, who's never seen anything like this before. And if his mom becomes agitated, that might be extremely scary for him. And he might blame himself, or he might think his mom is mad at him. There's all kinds of interpretations he might make of these symptoms. So let's talk about it. So we did talk about this, kind of, right? How we know that your patient is actively dying. All the things that you mentioned point to the fact that your patient's getting closer to death. And it's important for us to recognize that so we can help prepare the family and help make sure that the patient is as comfortable as possible. So in the months prior to death, yes, tend to eat and drink less, tend to lose weight. Sounds familiar? Functional decline. We need more and more help with activities of daily living. We might become chair-bound, then bed-bound. And yes, withdrawing from people and activities.
Yes. Sometimes they'll start talking about their time is coming to an end.
Yes.
The patient will be saying, I'm getting closer.
So Jennifer was saying that sometimes people know, they sense within themselves that their time is getting closer, and I always listen because I remember a patient in the hospital I was doing a palliative care consult on, and the patient said he was going to die that night. And if you looked at him, he looked pretty good. Yes, he had heart disease, and he was in the hospital. He was talking to his family. He called his entire family in, and sure enough, at about 1 or 2 a.m. in the morning, he died. He knew. So it's amazing that people can know that much about themselves. Are they always right? No, we're human. We fail. But I would take that very seriously if the patient is saying something like that. So in the days to weeks prior to death, often patients are only eating bites or sips. How long can someone live if they're not eating or drinking anything?
20
21 days, 25 days.
Anecdotal. They live to prove you wrong.
They live to prove you wrong. Hollywood tells us you can only live, 3 days without drinking? Yeah. But I've certainly seen someone live 3 weeks without eating or drinking. Yeah, it's amazing. And there was a medical student that went to my medical school who was in the Himalayas who went 6 weeks without eating. He was still drinking snow. 6 weeks without eating. He lost a lot of weight and he's still alive today. So the reason you don't die because you're eating and drinking less, you eat and drink less because you're dying. It's an active process. You don't die all at once, right? Your cells start to die gradually, and you get organ failure is kind of death of the organs slowly, and confusion is kind of disorientation of your brain as you're dying. So decreased urination, a sign of renal failure. Speaking less, so again withdrawing more. And confusion, most people are confused, so that the gold's buried in the backyard statement doesn't happen very often. Sometimes we do have people rally and they do say things, but the majority of us are going to be very confused right before we die. Is that your experience? Yeah. So sleeping more. So in the days to weeks prior to death, about half, slightly more than half of people are awake. A lot of people are developing difficulty swallowing, and we talked about edema. So edema can happen. Dependent edema, just edema from not moving around, and edema because your protein levels are probably reducing also. And again, that's not just about not eating and drinking. Your protein levels are dropping because it's an active inflammatory process. Cachexia is active inflammatory process. So it's important to remember. Now, patients and the family members particularly are worried that the medications that we're giving someone is going to make them worse, right? It's going to make them die sooner, and it's going to make them sleepy and not be able to interact. But even if we gave no medications at all, most patients are going to be sleepy and confused prior to death. And there's no evidence that the medications that we give, when given appropriately, hasten death. So the reason we're giving medications is to make people more comfortable. So even when family members are like, don't give anything because I want them to be awake. Well, even if we don't give anything, they're probably not going to be awake. So in the hours a day before death, so hours to days, people often not eating and drinking at all. Typically, patients are bedbound. And vitals can be completely normal. Vitals are not a great sign of when death is approaching. So, yeah, you can have a completely normal blood pressure, pulse oximetry, respiration rate, right up until when you die. So breathing changes, death rattle typically happens starts happening a couple of days before death. Certainly seen it longer and shorter. Not everybody gets the death rattle. Mandibular breathing is supposed to be the most accurate sign that death is close. So mandibular breathing is so the jaw dramatically opening with breathing. I hope I did a good demonstration. So when I see mandibular breathing, I'm never like, 8 hours till death. But I tell people if they want to know, again, you share information as people want. It's most likely that your mother has only hours, possibly days to live. So when giving prognostication, it's important not to be too accurate. Yeah. The death rattle, okay. The brief is that there's many different things that cause death rattle. As you get closer to death, the muscles in your throat relax. You're unable to swallow the small amount of saliva and secretions in your upper airway. You can get noisy breathing because you have secretions in your lungs as well, wheezing, the rate of your breath going through your throat changes noises, so there's multifactorial reasons why death rattle happens. Yeah. And typically not uncomfortable for patients, scary for families and caregivers, and even for us, right? So pauses in breathing, deep gasping breaths. We talked about modeling can happen, and cooling. Cooling's usually right at the end. But of course that can change if someone has peripheral vascular disease. They may already have cool feet. So increased confusion. So in the 6 hours before death, only 8% of patients are awake. The rest are either drowsy or asleep. And we talked about terminal delirium can be hypoactive, which is most patients. Hypoactive delirium is that quietly, pleasantly confused patient. And hyperactive delirium is that agitated, climbing out of bed, hitting, punching, screaming, yelling patient. And I feel like that's going to be me. Bring on the lorazepam. So when addressing symptoms, it's important to realize it's not just the patient, it's the patient and family. So discussing with the family, caregivers, MDPOA, proxy, whoever is most important to the patient will be taking care of them, what to expect. Because going back to the beginning, they've never seen this before, and of course every death is different. So they may have experienced one death, and that's an experience of one death, and this death may not be the same. I'm going to reassure and normalize symptoms. For example, the death rattle. I don't call it the death rattle to families, I call it noisy breathing. And if you talk about it, it's likely your loved one, that your mother may have breathing that sounds noisy. It's normal to be expected, and it's not uncomfortable for her. If she looks uncomfortable, then we have medication that we can give her to help with any shortness of breath. Repositioning. So we've talked before about repositioning on the side, for example, if someone has a lot of secretions. Repositioning for musculoskeletal discomfort. I just flew to London a few weeks ago, and sitting in one spot on the plane, oh my goodness, I thought I was going to get a decubitus ulcer by the time I got to Denver. So yeah, being in one spot can be really painful. So that repositioning is important for comfort. A fan. So a fan directed at the face can help with the sensation of shortness of breath. And the fan also provides some white noise. It can make the breathing noise changes less scary for the family if they're not listening directly to the breathing. And music. Music, I think, can touch people's hearts and souls even when they're unresponsive, because it's a different part of your brain. So if there's music that your patient likes from their generation, for example, preferably something soothing, I think music can help people to be more comfortable. Mm-hmm. And again, it helps. So the principles of addressing symptoms at the end of life. If someone has constant symptoms, one of the principles of hospice and palliative care is that we anticipate and relieve suffering. So we don't wait until someone's suffering. If their symptoms are already constant, we want to make sure that we're giving scheduled medications, because those symptoms are going to continue. If the medication is ineffective, then we want to titrate up the medication. And we'll talk a little bit later about what time to peak actually is and what it means. We want to think about what might be contributing to symptoms, but don't overemphasize that. For example, if the patient is constipated, yes, it could be contributing to their agitation, but it's probably not the only thing. If the patient has had decline, this patient's symptoms are probably more related to their terminal agitation. yes, you want to address the constipation, but don't overly rely on that and ignore giving medications for the other symptoms. And of course, address psychosocial and spiritual distress. And if anyone wants to comment about this, but I am certain that if the family is very distressed, the patient is going to be feeling that as well. Is that your experience? Yeah.
And it's also for the spiritual distress, what is the patient's perception of afterlife or beliefs? Because some are concerned about the mystery of the other side.
So Jennifer was saying their core beliefs and their beliefs about the afterlife might affect how they're feeling about death and dying for the patient and the family, I presume?
Yes.
Yes.
And if there's unresolved issues, that can also contribute to it.
So unresolved issues. And how many people completely resolve their issues before they die?
1%.
How many of you have resolved all of your issues? It's the fun of life. Jennifer and I were talking before. Failure is the door to opportunity. So when thinking about opioids and lorazepam and haloperidol, if we're giving scheduled medicines, we want to look at what the patient has already required and then schedule medicine. So for example, if we look at how much morphine someone has had for the last 24 hours, if we were to divide by 6, we can give a sixth of the dose every 4 hours around the clock. For lorazepam, it has a longer half-life, so you would divide by 3 and give an eighth. 3 times 8 is 24, and give it 3 times a day. And haloperidol, it has a much longer half-life, so the dose that you've given today, half of it is still there tomorrow. So you only give half of the 24-hour dose if you're going to give it scheduled around the clock. So what if the medications are ineffective? What do you do then? Send them to the care center. Yes. Absolutely. What might they do at the care center? They might give sub-Q, so they might change the route of administration. What? They could increase the dose. Change. I'm sorry. Try something different.
Frequency.
Yeah, increase the frequency. So there's many different things.
Atmosphere's different. Family. They may relax more. Family could be family, not caregivers. And stressed
Yes, so all that stress of being at home, at the care center, we surround them with people that are going to do the personal care for their patient, take care of the medicines, and the family members can just be family members and concentrate on that. Changes the level of stress. It changes the level of stress, and that agitation might just melt away because of the stress has gone down substantially. So for just on the medication side, so if a medication is ineffective and we haven't maxed out the medication, we want to increase the medication at the next dose. So we're going to talk about peak effect again in a minute. So if the patient, for example, is taking morphine for pain, and an hour later their pain is still 10 out of 10, the principle would be that we would increase that morphine dose by 100%. If the pain had decreased to about a 6, so it was partly effective, we might increase that dose by 25% or 50%. So giving the same dose, don't expect to have a better effect, right? And that way we can rapidly titrate. So if it's completely ineffective at a therapeutic dose, we want to reevaluate the patient. What do you think OIM is? Close. Opioid-induced neurotoxicity. So if someone is developing opioid-induced neurotoxicity, their pain is increasing as you increase the opioids, and it's going from one area to all over, and the patient's becoming delirious. So if you're increasing doses, they're getting worse. Think about something else might be going on. Maybe I need to rotate the opioids, for example. Or maybe I haven't noticed that their bladder is distended, or they have constipation, or there's psychosocial or spiritual distress that needs to be addressed. Think about changing to a different medication. Think about adjuncts. For example, cancer pain, maybe they need some steroids, for example. Psychosocial spiritual distress, maybe this is the rare patient that needs some kind of intervention. Maybe, and I don't know that I would recommend palliative radiation in the last few weeks of life, but if this was not someone actively dying, think about other things that we might do. Maybe they need the fluid drawn off of their very tight distended belly to resolve their symptoms. And rarely, maybe they need palliative sedation. So we have other tools in our toolkit if the patient's symptoms are not getting under control. And absolutely, the care center is a great place for patients and families to be if their symptoms are out of control. So we're going to be talking about pain, shortness of breath, agitation, and nausea. So patients can be in pain for many different reasons. Their terminal illness, for example, cancer, may be causing them pain. And they may have been on pain medicines for months. We already talked about the musculoskeletal pain of just lying in one place. And delirium removes that filter. So normally, if you think about a 2-year-old who hurts themselves and carries on, if we hurt ourselves, we have our frontal lobe filter. So we still feel that pain, but we don't express it the same. When you're dying, the delirium takes away that filter, and you become disinhibited, and you experience pain at a higher level. In fact, there was a study showing that haloperidol might be a useful adjunct for pain with terminal delirium at the end of life. And I suspect it's because it helps improve that filter. But that's just my theory. So pain AD score, which you use for your demented patients, might be helpful if someone's unable to tell you if they're in pain. Grimacing, of course, moaning, yelling out, restlessness. It can be very tricky to know whether someone who's agitated and restless, is it pain or is it delirium? And it might be both. Can you think of some ways to try and tell the difference? So you might look at their face and how they're grimacing or holding their hands. Mm-hmm. Or moving their legs.
Sometimes with someone in a lot of pain, they also kind of reposition themselves.
Yeah, maybe they look like they're more repositioning than just randomly moving.
Sometimes they withdraw from touch, or maybe they just really don't want to be messed with.
Maybe they don't want to be messed with. Mm-hmm.
I do have a difficulty understanding this delirium part. What does delirium look like?
So what does delirium look like? Does anyone have an answer?
They want you to act again.
Sudden onset, yes, absolutely. Any other? So yes, delirium is typically due to underlying serious health issues. It's usually acute onset, so within minutes to hours, rather than dementia, which develops slowly over years. It fluctuates, so one time of the day they might be really good, and other times of the day they're super confused or agitated. It's associated with poor prognosis. I think of delirium as brain failure. So it's very hard. The brain is the most metabolically active organ that we have. So when you're dying or you have organ failure, it's much harder for your brain to think clearly. So you get this fluctuating course of confusion. You get altered consciousness. You can either be sleepier or hyperactive. So hyperactive meaning agitated. So those are the three hallmarks of delirium: fluctuating, acute onset, underlying medical condition, and the third thing I just said. I did say it all. I just didn't repeat it. Fluctuating. Anyway, so it's brain failure, yes.
So my question would be then, because I had a doctor ask me if what I was looking at was terminal delirium versus terminal restlessness. I didn't know what that was. No, I couldn't give that answer to him because I didn't understand.
Sure.
What would be the
So what's the difference between terminal delirium and terminal restlessness?
terminology?
Yeah, I think terminology. I think, restlessness at the end of life can be due to delirium as well as other things. Pain, constipation, many different things can cause restlessness. Delirium is the brain failure part. And it would be very unusual for someone to be dying without some degree of terminal delirium. So it's the cognition part. Attention, cognition, fluctuation. I think we've got it. So opioids are first line for pain at end of life. And again, opioids have not been shown to hasten death. And I would recommend that you bring that up with families because that's probably in the back of their mind even if they're not saying it. Starting doses of opioids, morphine, we typically use 5 milligrams. Why don't we use morphine for pain when people are not dying? Why do you think? Addiction, maybe? Side effects, maybe? In someone that requires opioids, why isn't the primary care provider prescribing morphine?
Something lasts that's not.
So they're concerned about potency? What do you think? Not potency. Neurotoxicity? My personal opinion is,
Got a bad reputation.
yeah, I think there's a lot of misconceptions about morphine. Morphine doesn't come in a 5 milligram IR pill, so it doesn't come in an appropriate dose. The IR morphine is 15 milligrams, which is way too much for the average person. And because of these misconceptions, morphine is less potent than oxycodone and hydromorphone, right? So I'm just telling you this to remember that your family members and patients are worried about morphine because they've heard all this bad hype about it. Morphine is also cheaper, and it's available in liquid concentrate. So it's not super cheap, but it's more available, and we can give it as a liquid concentrate at the end of life. And the good thing, there's great evidence. Morphine has the most evidence with use at end of life and in palliative and hospice medicine. So we use it because it's evidence-based, it's available, it's in liquid form, and it's not stronger than the other pain medicines. We use it because of its convenience factor and because it has great evidence behind its use. So 2 milligrams of IV morphine is about equivalent to 5 milligrams of PO and 0.3 of hydromorphone. So there's about a 3-to-1 conversion. The medicine is passed through the liver. So when you take 5 milligrams of morphine by mouth, you only end up with a third of it in your bloodstream because your liver takes care of it when you're digesting it. Of course, you should start slightly lower doses if your patient is really cachectic or elderly and never been on opioids before. And if they're already on opioids, you're going to start according to what they're already on. So it'll probably require higher doses. Time to peak, finally. So what time to peak means, if I take a 5 milligram dose of morphine by mouth, in 1 hour it will have reached its maximum effect. So it's not going to be any more effective 2 hours from now or 3 hours from now. 1 hour, it's at its maximum effect. which means it's safe for the patient to have another dose of morphine at that time. If I give the dose sooner than that, then the doses will tend to stack. So for morphine and hydromorphone, which is the most commonly used medications that we use, and it applies to oxycodone by mouth, time to peak is 1 hour, and subcutaneously about 30 minutes, and IV about 6 minutes. Duration of action, it lasts about 4 hours, and that's why we tend to dose it every 4 hours around the clock for short acting. And half-life, about 4 hours. There's no ceiling effect of opioids. In other words, you could keep escalating the doses except for the adverse effects, of course. I'm not saying that you can't overdose on opioids. Of course you could overdose on opioids. But in someone who's opioid tolerant, you could potentially continue to increase the medicines and you'll get more analgesic effect. A medicine that we also use that does have a ceiling effect would be something like tramadol. Tramadol has a ceiling effect, meaning that if you get to 300 milligrams, if you go above 300 milligrams, you're not going to get any more analgesic effect. It's not going to relieve pain anymore. But that's not true for morphine, hydromorphone, oxycodone. The adverse effects, we already mentioned opioid-induced neurotoxicity. What other adverse effects of opioids? Constipation, yes. Urinary tension? Drowsiness and sleepiness, yeah. Confusion, respiratory depression if we went up too quickly. Nausea, absolutely. And itching, yeah.
I noticed that some people have Narcan that's being brought out to their homes.
So Narcan, yes. So Narcan's being used more in the community because of the opioid crisis, right? To reduce risk. So it's a reversal agent for opioids. So very tricky in hospice patients, yeah. But patients who have chronic non-cancer pain in the community, the hope is that if someone accidentally takes too much or takes something else that's sedating and potentiate the sedating effects of opioids, that Narcan will help save their lives. And Narcan has helped many teenagers and 20-year-olds to save their lives, and that's what we want.
In hospice, though, because it is in the homes now, of course it's not on our standing orders, we would definitely go to you if we ever use it.
Yes.
But it doesn't sound like we would ever really want to use it.
So talking about Narcan, when would we use it in a hospice patient? What do we do with it? I think it's important if a patient ever does use Narcan, absolutely. I think that's an immediate physician call, nurse practitioner call, because that means there's something wrong with their medications, or it might be they're not using it appropriately. I think teaching around Narcan, and maybe this is a whole nother talk, I think once the patient is actively dying, the family need to be instructed not to be giving Narcan because it immediately causes acute opioid withdrawal. And when you're dying, that's probably not the right thing to do. Yeah. Yeah. Yes.
I've been, I'm a float nurse, so I go into homes and the patients sometimes are instructed, or patients' families are instructed to give the morphine, even though it's a PRN, but to give the morphine no matter what in 2 hours or 3 hours. So my question for you is, if it's PRN, if the patient is sound asleep in that 3-hour mark or whatever they've been told, is it really, do they have to set their clock in the middle of the night to get up to give the patient who's sound asleep, who's relaxed, that medication?
So talking about...
Because I'm on that other end. I don't want
Yeah.
to say, this is what the RN case manager says, so I'm going to go behind and say exactly the same thing. I look at caregivers resting and such like that.
So asking about PRN, this is actually 2 questions in here. PRN medications, passing on, hey, you should instruct the family to give that regularly. And the other part of the question was, should the caregiver wake the patient up or wake themselves up to give the medicine? I think number one of the question needs to be taken offline, because I worry about nursing practice telling families to give patients PRN medications scheduled without an order. I would strongly recommend that you get an order to cover yourself, because when a medicine's ordered PRN, and if you're not giving it PRN, then you're not following the order. And should the caregiver wake up the patient? I think that depends. If you don't give every 4 hours around the clock, then the patient might have some withdrawal or breakthrough symptoms. So I think it would depend on the patient.
But only if it's sick.
Yes.
Okay, that's all I wanted to kind of clear up.
Yes.
I wonder if you hopefully have been in the note.
Yes.
Documented somewhere. I know sometimes there's family members that are so afraid of those medications and so resistant to them.
Family members are resistant. Don't wait until the pain is 10 out of 10. Give it when it's 5 out of 10. Or
Go ahead for the next couple of doses. Give it to them every 4 hours, because you know that by hour 5, they're toiling, they're crazy, you're calling us because we're in crisis again. But again, hopefully that's in the note.
Well, that's
been
kind of where I'm at. That's exactly what I'm asking about. Is that, so this is what I'm hearing from the family. I don't see necessarily in the note. And my question is simply, I do agree, and I understand the catch-up mode.
Yep.
In the same question, my question is, if it's PRN, it's
Yes.
still my
So
question.
the question is about PRNs. So I think this part needs to be taken off of this talk. I would strongly recommend, if you're giving medicines, if patient needs scheduled medicines, get an order for it.
I'll also say from a triage perspective, I get families calling me in the middle of the night that they've had a decline. Like today, they're unresponsive. They haven't, like one this past week, the lady had been asleep for 12 hours. And they're like, she hasn't, she was last medicated like at 11 o'clock in the morning. And they're like, so should we wake her up before we go to bed? And I'm like, okay, so what was her usage before when she was awake?
Yeah, that can be
Frequently?
tricky.
And they're like, well, she was taking it every 4 hours routinely. Or it was her PRN, but she was wanting it every 4 hours. And I was like, well, I would caution you to not wait more than 6 hours before medicating.
Yeah, it's
Because
tricky.
you're probably going to get in crisis. So wake her up, see if she's hurting, reposition her, and probably get the medication.
Yeah. So that was just more about the PRN medicines for those listening to the more of the same discussion. So for constant pain, we talked about this before. You want to look at the 24-hour requirements and get an order to divide that by 6 and give scheduled Q4 hours around the clock. So let's talk about Mr. Gregory. He's 78. He has metastatic lung cancer to the bone and brain. He's had increasing severe cancer pain in his right humerus every time he moves his arm. It's constant pain. He's not eating and drinking. He's bedbound. He's already taking dexamethasone, which at the moment he's still able to swallow. He's refused to take any opioids up until now. Maybe he's a veteran. He has no allergies and no known renal failure. What would you do? What are your thoughts?
5 milligrams every 4 hours.
Maybe 5 milligrams every 4 hours PRN?
2.5 because he's elderly and
Maybe
Opioid
2.5
naive.
milligrams. He's opioid naive, he's elderly, and he's really nervous. And he has severe pain, severe cancer pain, yeah. Maybe an NSAID, although he's already taking dexamethasone, and he may not be able to swallow very long. So, again, I want you to be thinking constant pain. Let's not wait for another 24 hours before we start thinking about scheduling medicines. I know this is a little bit different. But I would start at a lower dose, the 2.5, just because he's nervous, he's old, he's never taken opioids, and if we give him 5 and he sleeps all day, he's going to be like, I'm not taking it again. And what are we going to be warning him right up about morphine? Constipation! And we're going to get him on something for constipation, right there. So, and we're going to do daily visits because we see that he's already declining, right? So, the next day he's followed up and he's taken his 2.5 every 4 hours around the clock, and he's also taken additional 5 doses of 5 milligrams of morphine. So he's taken 40 milligrams in the last 24 hours. What would you do? What would you be thinking? The increase is scheduled. What would you increase it to? And you have calculators on your phones. 506? Yeah, why not? And I made it kind of more exact in this example. 6 milligrams Q4 hours, or you might do 5 milligrams every 4 hours around the clock. And make sure that his PRN, remember, especially for cancer patients, but any patient, time to peak effect is 1 hour, so we'll be dosing the PRN every hour as needed, especially when someone's dying. And if he wasn't actively dying, we could have potentially given him morphine ER. Right? So let's move to shortness of breath. So shortness of breath can be related to why the patient's dying. They might be a COPD patient, they might have heart failure, they might have ALS, or that tachypnea, rapid breathing, is not always dyspnea, right? So tachypnea could be metabolic acidosis from the progressive renal failure. Maybe they have diabetic ketoacidosis. Maybe they're really anxious. And of course, dying changes how your breathing looks. So we talked before about fan direct to the face. There was a study, again, just remember, comparing fan versus oxygen. When someone has normal oxygen level, a fan works just as well. So, and there was another study comparing fan at face versus fan at your feet, and the fan at your face works better. It feeds back into your brain, to your respiratory center, and relieves dyspnea, so it's not hocus pocus. Oxygen can be helpful if the patient's hypoxic, but remember it might prolong the dying process. So thinking about goals of care, not everyone wants to prolong their dying process. So of course, opioids for dyspnea, and usually half the dose that's effective for pain is effective for dyspnea. So if someone is completely opioid naive, I would even start at 2.5 of morphine. Opioids have not been shown to hasten death if given appropriately. Think about constipation. And I think it's really important to understand yourself and to tell the family that the patient's breathing is not going to look normal. When they're actively dying and they're tachypnic or they're gasping or they have mandibular breathing, the morphine doesn't convert their breathing to normal breathing, right? So it's important to reassure them, even though your mother breathing looks like this, the morphine is relieving their feeling of shortness of breath. And it relieves it because it affects the respiratory center where you feel short of breath. It's not because it makes your breathing less or it makes you relax. It's because it affects your breathing center. And we don't know exactly why, but it does have an effect on that shortness of breath, that air hunger. And opioids should be given for discomfort, not just for a particular respiratory rate. A respiratory rate of 40, yes, I'm thinking, yes, they're probably short of breath. But we're not going to make their respiratory rate 18 or 12. That's not the goal. The goal is to make them comfortable. So if you're giving opioids and they're no longer grimacing, or if they're able to tell you that they're no longer short of breath, then they're no longer short of breath, right? So if they have constant dyspnea, then again, we want to give scheduled around-the-clock opioids. and relieve the dyspnea first, and opioids also help with anxiety related to dyspnea. If they're still anxious after you've relieved their dyspnea with opioids, then benzodiazepines can be helpful. Second last. Agitation, restlessness. Mostly secondary to terminal delirium, but lots of other things that can contribute to it. Uncontrolled pain or symptoms, constipation, urinary retention. Maybe it's too loud, too noisy, too bright, too many family members, too scary. Maybe they're going through withdrawal. Now, medication withdrawal, it's important to pay attention. Your patients who are on antidepressants, if they suddenly stop swallowing them, they're going to go through withdrawal. So they're going to need a little bit of benzodiazepines to help with that. Yes?
So withdrawal symptoms, back to what she was asking about. If somebody's getting it every 4 hours during the daytime and then they're sleeping for 12 hours at nighttime, is that withdrawal or does that
They
play
can.
a factor into the nighttime restlessness that people have?
Absolutely. She was saying if someone's taking Q4 hours during the day and then they sleep 12 hours, they have missed a couple of doses, they'll get some withdrawal. And these medication fluctuations contribute to delirium. And of course, if they're getting breakthrough pain or dyspnea or agitation as well. So yes.
Sometimes I think of withdrawal as maybe a day or two after, but no, it's hours.
It can be hours if it's a short-acting medicine, yes. And of course, don't forget psychological and spiritual distress. So benzodiazepines are considered first line for terminal delirium and agitation. I'm not talking about agitation in patients who have months or years to live. I'm talking about patients with terminal delirium. Because benzodiazepines help with amnesia. They help you forget what's going on. If you had severe agitation, would you want to remember it? No. And lorazepam is sedating. Unfortunately, haloperidol is not sedating. So it helps, it doesn't reverse the agitation, but it helps relieve the symptoms. And again, constant agitation, medications around the clock. And I would even start as low as 0.5 twice a day of lorazepam. And if someone's withdrawing from their antidepressant, I might just give 0.5 of lorazepam at bedtime. That might just be enough. But anticipate, they've stopped taking this medicine, I need to give something to help with the withdrawal. Again, time to peak, it's about the same as if you give it sublingual tablet like we do, it's about an hour. Duration a little longer than opioids, so 6 to 8 hours. Maximum dose of lorazepam, 40 milligrams in 24 hours. We rarely get anywhere near that. So haloperidol, I sometimes add if they have hallucinations or delusions. There was one study suggesting that haloperidol might increase risk of mortality. Again, risk versus benefit versus burden. The ethics of giving a medicine that might affect mortality, if you're giving it to relieve a symptom and not to hasten death, it is still ethically okay to give the medication. And I don't think we even have enough evidence-based medicine to say one way or the other what is appropriate to do in the last weeks of life. Because it's very hard to study people at the end. Think of the ethics of studying people at the end of life. Are you going to do a placebo-controlled randomized trial on someone who's dying? Yeah, tricky. So haloperidol, keep in mind, it's not really sedating at all, and it doesn't help with anxiety. Starting dose, usually 1 milligram. So time to peak a little longer, 2 to 6 hours. So if you give it Q1 hour, you're going to get dose stacking. Duration, the half-life is much longer. Maximum dose is actually pretty high. So nausea, think about contributing symptoms such as constipation, absolutely medications like opioids, uncontrolled pain can certainly make people vomit. Haloperidol is first line for most of our patients who are actively dying. Dexamethasone maybe if they're still swallowing. And if someone has constant nausea, again, the principal, schedule medicines around the clock. If one medicine is not effective, then think about increasing the dose to a higher dose and adding a medicine from a second class. For example, if they had complete malignant bowel obstruction, scopolamine, which is not on our formulary, might be helpful. Ondansetron might be helpful if they have renal failure or liver failure. Gland, I don't use that very often, but if someone had partial bowel obstruction or ileus, that might be helpful. So we've already had a talk on IV fluids before. Just a quick reminder, IV fluids don't prolong the dying process. Does not increase noisy breathing at the end of life. You'd want to avoid it in heart failure, edema. There are conflicting studies about whether IV fluids help with delirium or make it worse. In patients, it's not us that has to live the person's death, right? So if a family feels that this is really important, as with anything, a time-limited trial. So let's try this for 24 hours and see if the hopes that you have, what are the hopes that you have? Most people hope that either symptoms are going to go away, or they're going to be more alert, or they're going to feel better. Let's see if those IV fluids actually do that, and we're going to be watching out for signs of volume overload, like edema and heart failure. Most people don't want IV fluids, but studies show that most people want to talk about it. So just be aware of your own biases. We don't very often give IV fluids at the end of life, but it's not all about us, right? So death rattle, no evidence that anticholinergics like sublingual atropine drops or scopolamine or glycopyrrolate are effective. It tends to fluctuate and generally improves as you get closer to death, as you dehydrate. Repositioning is helpful. We talked about white noise and music. Anticipatory guidance, telling the family that this is to be expected. It doesn't cause discomfort. If your family member, if your mom looks like they're short of breath, we have this morphine here to help with shortness of breath. So back to Mrs. Gohart. Do you remember her with heart disease? She's mostly unresponsive. She's grimacing. She looks like she's short of breath at rest. What do you think? Some morphine. Sure. A little bit of morphine. Little drops of morphine for her. What else are you thinking? We're going to look at her meds and make sure that she's not going to be withdrawing from something, right? Well, anticipatory guidance, we're going to be talking to the son about what's to be expected. And then, so her patient care kit was opened. She ended up receiving morphine and a little bit of lorazepam. What would you do next? Yeah, think about scheduling it, right? How much would you schedule? 5 milligrams of morphine Q4. Yeah, why not? It's likely that her symptoms are going to continue. In fact, you probably noticed that symptoms tend to get a little worse as you get closer to death.
And also PRN doses.
Absolutely, need some PRN doses as well. And you'll instruct him how to take it, of course, how to give it. So we're going to comfort the son. We're going to discuss what to expect. He's going to be on daily visits. We might try FAN. We might give the morphine, 5 milligrams every 4 hours around the clock. Probably it's a good idea to go ahead and schedule a little bit of the lorazepam too, because if she's been agitated for the last little bit of agitation intermittently, that's probably going to continue. Okay, Mr. Dinor. 75, end-stage COPD. He's actively dying. He has terminal agitation. He's normally on morphine 15 milligrams ER BID for chronic pain and takes morphine 5 Q4-hour PRN, and he was taking sertraline for anxiety. A lot of people get COPD because they use smoking to self-treat their anxiety. So what would you do with him? I'm sorry, lorazepam? Mm-hmm. Maybe schedule some lorazepam? Mm-hmm.
If you have terminal agitation, would you go to Haldol first? Benzos.
Benzos. What about his morphine ER that he can't take anymore? Schedule short acting. How much would you schedule? 5Q4. Yes! So 5Q4 will give him this 30 milligrams a day, which is what he's been taking. So we don't want him to be withdrawing. This is not the time for him to withdraw from morphine. Right? And PRN, yep. So we'll increase his PRN to Q1 hour PRN because he's now he's getting close to actively dying. Give him a little bit of lorazepam for his sertraline withdrawal and make sure he has some more of that. And titrate up. And if that 0.5 milligram of lorazepam is not enough, then we're going to titrate that up. But that's the starting dose. Questions? Comments? Yes, Carly.
I've noticed that you said there was no evidence with anticholinergics. I've seen the secretions. I've seen those ordered before, relatively frequently. Why is that if there's no evidence? Why is it ordered?
Why do we give anticholinergics if there's no evidence? Because we like to do something. Yes, we are healthcare providers. We can fix it. Do you remember when we had ABH gel? You might not remember, but we had this gel. It was ABH or ABHR. It had Ativan, Benadryl, and haloperidol, and you rubbed it on the wrist, and everyone swore by it. Yes, it helps with agitation and nausea. Woohoo! And then someone studied it and found out it wasn't even absorbed through the skin. So I guess now we rub in lotion. So we do things. So anecdotes are very powerful. So when we believe something works and we see someone improve, it's a very strong testimony. It reinforces our belief. And if we believe it works and it doesn't work for someone, we just ignore it. It's subconscious. It's like when you read a book, if you find something in there that you agree with, you're like, this is the best book. If someone else reads the book, they'll get something else from the book and they're like, they'll ignore the bit that doesn't agree with them. So it's bias. So there was a placebo-controlled randomized controlled trial which showed that it didn't work. And I think the reason that we thought it worked is because it tends to fluctuate. So, and I don't know, evidence will probably change in the future and we will adjust our practice according to what we find out in the future. But it's human nature to want to fix things. Any other questions or comments?
Any comments on methadone?
Methadone. What do you want specifically about methadone? So methadone is an opioid just like any other opioid. It has some special properties because it's much longer acting. It has the same side effects as any other opioid, except it also prolongs QT, which means it has potential cardiac effects at higher doses. I find methadone is very effective, especially for young people with cancer pain. So it has its place. It's not good for people who are non-compliant with medications. I wouldn't recommend it for people with chronic non-cancer pain. But in the right circumstances, it's a great medication, and you should not stop it when someone's actively dying. You should continue to take it. We have the 10 milligram per ml concentrate available when someone's actively dying. Did I answer your question?
Yeah, it was being used when I was doing
Yep.
and it seemed like the side effects were not as much as we wanted.
Yeah, I think, methadone, so side effect-wise of methadone, it doesn't cause opioid-induced neurotoxicity like morphine does. So if someone is having escalating doses of morphine or even hydromorphone can cause opioid-induced neurotoxicity. If someone's on escalating doses of opioids and getting severe side effects, rotating to methadone can be very effective.
And also, I restored a patient was actually dying the third day using methadone, and it was because the half-life was longer. And so after initiating, you had to monitor it.
Yes, so when methadone is given, it takes 5 to 7 days to reach a steady state. So it's important that the prescriber has experience prescribing it, and that if someone is becoming sleepy on day 3, that it's looked at, is this the methadone or is this disease process? Yeah, absolutely. Thank you. Well, have a great day, everybody. If you have any other questions, email me. And thank you for doing a fantastic job.